Good afternoon, dear colleagues, ladies and gentlemen. I must thank Dr. Chaminda Gamagi, the President of the Work Clinical Society, and Dr. Ruchira Nadira, Consultant JMO, for inviting me to conduct this guest lecture to contribute to the annual academic sessions of Work Clinical Society. My topic today is professional negligence in medical practice. Before talking about human negligence, we have to know certain definitions. Human error. The subject of human errors have been extensively studied in other industries. Cognitive psychologists divide errors into errors occurring in automatic mode, known as slips. These slips occur during fatigue, interruptions, and anxiety. And there are errors occurring in problem-solving mode, known as mistakes. Mistakes occur due to incomplete knowledge and the tendency to apply rules to simplify problem solving. There are so many types of medical errors, including medication errors, errors related to anesthesia, hospital-acquired infections, so on. Root causes of medical errors include communication breakdowns, inadequate information flow, human problems, patient-related issues, insufficiencies in training, inconsistent or inadequate education. Relationship of medical errors to adverse events. Medical errors and adverse events overlap in certain areas. Those are known as preventable adverse events. These adverse events are occurring due to medical errors. Some of these preventable adverse events come under medical negligence. All errors are not negligent. Medical negligence is failure to meet the standard of practice of an average qualified physician practicing in the specialty in question. Negligence occurs not merely when there is an error, but when the degree of error exceeds the accepted norm. Medical negligence is not only a matter between two parties. Doctor-patient relationship. It is also a political issue. Medical negligence actions are often destructive of trust in a doctor-patient relationship, distort the medical practice in an overcautious direction, very stressful and demoralizing for doctors. What lies behind increased litigation? Modern medicine is more intrusive and chances of injury are high. Current social climate encourages expectation of cure. Consumerism, patient right charters, and media advocate allocation of blame. Malpractice litigation is increased because of breakdown of communication between doctor and patient, unrealistic expectations of the outcome, high and increasing cost of medical care, higher public awareness about litigation in all areas, right to health care. Problems in negligence litigation. Patients have great difficulty in seeking compensation, face of some hurdles in suing a doctor. In UK, many cases up to 83% fail. Cases are delayed 3 to 4 years. It is socially very expensive. Only the lawyers who benefit. Isn't there any good in medical negligence litigations? it is said to be a deterrent. If threat of litigation removed, the care with which doctors treat their patients will be adversely affected. Surveys in the US indicate that successful litigation provokes greater care. What is medical negligence? Negligence in general is doing something known as commission, which a prudent and reasonable man would not do, or not doing something, omission, which a prudent and reasonable man would do in a given situation. Medical negligence is failure to exercise a reasonable degree of skill and care in the management of a patient. It is the breach of duty of care by an act of commission or omission towards a patient which results in a damage to the patient. Liability of medical negligence lies in civil courts. The plaintiff will ask for compensation. Medical negligence is considered criminal when the doctor has been grossly negligent as to have no regard to the life of the patient. Medical negligence is established when doctor owes a duty of care to the patient and there is a breach of that duty by an act of commission or omission. A damage or harm is in fact caused to the patient and a causal relationship exists between the breach of the duty and the damage caused to the patient. Key question in negligence case is whether the standard of the treatment given by the defendant fell below the standard expected of him by the law. To establish the liability by a doctor, it must be proved that there is a usual and normal practice. The defender has not adopted that practice. The course the doctor adopted is one which no professional of ordinary skill would have taken if he had been acting with ordinary care. The concept of reasonably skillful doctor. The doctor is not expected to be a miracle worker guaranteeing a cure or a man of very high skill. He is the practitioner who follows the standard of practice of his profession, or at least follows practice that would not be disapproved by the responsible opinion within the profession. He should be skilled and updated with new knowledge. Breach of duty of care. Duty of care is the undertaking to take all due care necessary for the well-being of the patient. It requires diligence, thoroughness or attentiveness, care, knowledge, skill, and caution. Duty of care arises with the establishment of doctor-patient relationship. Strictly from a legal point of view, there is no duty upon any doctor to undertake the care of a patient, whether in an emergency or otherwise, outside usual practice hours. Once undertaken, doctor becomes legally liable for consequences of their negligence. This is so even when they act in voluntary capacity, whether or not they receive a fee. Medical practitioner may be negligent by failing to exercise fair and reasonable standard of care and competence. Medical practitioner may be negligent by misdiagnosis, by not exercising sufficient care to follow standard accepted steps to make the diagnosis, failure to listen to patients' complaints properly and investigate, negligent operating or post-operative treatment, administering, prescribing a wrong drug, wrong dosage, wrong route, negligent exposure to risk of infection, negligent advice or failure to warn about the risks, inadequate supervision of inexperienced subordinate staff, breach of confidentiality of information about the patient. Misdiagnosis. A doctor is expected by law to use the same degree of care in making a diagnosis as in all dealing with patients. A mistake in diagnosis will not be negligent if the standard of care is observed. Failure to take a proper medical history, failing to conduct standard clinical examination, failing to conduct tests, failing to evaluate the results of tests and take appropriate action, simply failing to diagnose a condition which would have been spotted by a competent practitioner. These are examples of mistake in diagnosis. In case where a doctor doubtful about a diagnosis, good practice may require that patient be referred to an appropriate specialist for further consideration. Negligence in treatment. Important to make a distinction between excusable medical mistake and mistake amounting to negligence. Gross medical mistakes almost always are negligent. Use of wrong drug, performing an operation on wrong patient, removal of wrong limb, leaving operating equipment inside patients after surgery. A consultant could be negligent if he delegates responsibility to a junior knowing that he was incapable of performing the duty properly. In court of law, experience is irrelevant for degree of competence. An inexperienced doctor occupying a post in a unit offering a specialized service needs the degree of expertise expected of a reasonably competent person. Actual hospital rank is irrelevant. This is applicable to incidents where senior house officers or registrars go and see the referrals to the consultant. Gives rise to an inference. Recipes locito gives rise to an inference of negligence on defendant's part. If defendant cannot rebut this inference, plaintiff will have established the case. Confidentiality. Respect the confidence of patient. The doctor is under a duty not to voluntarily disclose without the consent of the patient information which doctor has gained in his professional capacity. Exceptions to confidentiality. In patient's interest, discuss, advise close relatives on rehabilitative preventive activities. In the interest of society, we may have to inform police, inform MOH notifications, and give testimony in courts. Other special circumstances like medical examinations, medical certificates, death certificates. Consent to publish includes allowing trainees to be present at examination of patients. This exception should not be misused, disregarding patients' dignity and autonomy. Loss or damages. In general, pain, suffering, and loss of amenities are known as damages. Special losses include loss of earning capacity, loss of earnings, loss of expectation of life, hospital and home costs, loss of spouse's earnings and value of his/her services, cost of transport, wheelchairs, other equipment, cost of providing or adapting accommodation. In negligence case, a doctor can have defenses. Main available defenses are assumption of risk by the patient, contributory negligence by the patient, denial, inevitable accident, or misadventure. Assumption of risk by the patient means some procedures have inherent risks. The patient giving consent accepts the risk willingly. If the doctor has warned those risks and patient suffers subsequently, doctor cannot be held negligent. This is where the value of informed consent comes in. Second defense is contributory negligence by the patient. if the patient fails to divulge vital information in the history. Patient fails to follow instructions of drug therapy or diet. Fail to keep follow-up appointments. Leaves against medical advice. Continue to smoke or take alcohol. Doctor can deny negligence when there is a genuine mistake. Mistake of diagnosis likely to occur due to the patient's symptoms and signs when they are vague or atypical. Presence of other possible causes of damage. Example, intervening event. Negligence of other member of health staff is another reason for denial. Inevitable accident or misadventure. Fatal anaphylactic reaction despite administration of drug with you. Power failure during surgery. Medical records are very useful evidence for defense of doctors, provided they are of good quality, they are contemporaneous, clearly, correctly, and properly written, legible. BHT, clinic notes, diagnosis card are medical records. They should be clear and neat, follow an accepted norm, date and time, grammatically correct, recording of facts, findings, requested investigations, diagnosis and other opinions, instruction to nurses, avoid irrelevant things, theory, end of each entry should be signature of the doctor. DUUA. Can any one of you understand this? This is my own abbreviation. It is the same when you use abbreviations of your own or one specific to one or the other specialty. So don't use unauthorized abbreviations. How can doctors safeguard themselves and their patients? Improve the knowledge by continuous medical education. Modify attitudes. Adherence to principles of medical ethics. Behavioral modifications. Care, self-respect, and respect to patients, and reflect back. I have brought a few cases for discussion. These are my personal professional experience. None of these cases ended up in courts, probably because majority of Sri Lankan ordinary patients still respect doctors. This is a case of breach of confidentiality. 21-year-old unmarried sales girl committed suicide. Earlier, she had got a termination of pregnancy done as boyfriend refused to marry her when she became pregnant. From Jinwat, case was reported to police. The police officer had gone to her workplace and recorded a statement from a fellow employee, having disclosed the fact of her pregnancy and abortion. Disclosure of information had led her to commit suicide. SLMC guidelines clearly say not to report cases of termination of pregnancy without consent of the patient. Case of misdiagnosis. A 35-year-old mother of 4 died on day 4 after emergency cesarean section. Cause of death was pneumonia, bronchopneumonia. BHT showed daily status written by HO as this: 11th, no complaint; 12th, no complaint; 13th, no complaint; 14th, no respiration. There is misdiagnosis, failure to take proper medical history, failing to conduct standard clinical examination, failing to conduct necessary investigations. Another case of misdiagnosis. 19-year-old female. LRMP was not known, has no periods after first delivery. Treated at a base hospital for bleeding PV. Urine HCG was positive, but no ultrasound scan was done. Diagnosed as straighten abortion, kept under observation and bed rest for 3 days and discharged. But unfortunately, she was admitted to local hospital next day and found dead on admission. Autopsy revealed ruptured tubal pregnancy. Again, misdiagnosis due to failing to conduct necessary investigations. Case 4. A boy, 11 years, admitted to hospital with history of fall from a tree and prick of dried piece of wood on anterior abdominal wall, right inguinal fossa region. Exploratory laparotomy was done by surgical registrar, found no perforation to peritoneal cavity. But he has done routine appendicectomy, discharged the patient next day for home care. Third day after surgery, child developed abdominal pain and vomiting, being at home. Treated by local doctor, in fact an EMA, estate medical assistant, in the estate where he lives, with a blue color syrup, probably Finnegan syrup. Child slept well, but collapsed by next morning. Rushed to hospital, again found dead on admission. PM revealed peritonitis following infection of original bone tract on anterior abdominal wall, extending onto appendicular abscess involving appendicectomy stump. Exceeding limits of consent, unnecessary non-life-saving procedure, inappropriate treatment plan. Case 5. 45-year-old male laborer collided with another motor bicycle as he came out of factory around 6:35 a.m. riding his motorbike after night shift duty. Helmet had not been properly worn, ejected off as he fell on tarred road. Rushed to hospital, accident and emergency. GCS was 13 on admission. 4 centimeter laceration of scalp was cleaned and sutured. Tetanus shots were given. Skull X-ray was requested and done. Kept under observation. By 9 a.m., patient was conscious and rational. Talking and walking in ward. Insisted on discharging him as he wanted to go home and sleep to get ready for the next night shift again. Doctor discharged the patient, not awaiting the X-ray films. 5 p.m., patient was readmitted but found dead on admission. Inquest revealed, PM after inquest revealed, cause of death of EDH, extradural hemorrhage following in linear fracture of right temporal parietal region of skull. No evaluation of conducted investigations and failure to diagnose. A 6-year-old boy was admitted at 12:45 p.m. following stray dog bite as he returned from school. He had deep bleeding wounds on right palm and thumb. Wounds had been washed with soap and water by parents before admission. Tetanus toxoid was given and patient was sent to operation theatre at 2 p.m. for ARSIR, as was the practice those days in view of anaphylactic reactions and resuscitation needs. At OTSH, had noticed that boy had his last meal at 10:30 a.m. during the school interval and immediately sent the patient back to ward with the instructions to send him to OT next day at 10 a.m., having kept fasting from 10 p.m. ARS was given almost 24 hours after the alleged dog bite, but child developed rabies on 7th day after the dog bite and died. Postmortem confirmed diagnosis of rabies. Failure to take proper history, poor and careless decision making. What are the common issues which need immediate attention in Sri Lankan practice? Crowd clearing attitude. Often inadequate care is given to patients who are already under care in order to cater the next to come. Deviation from clinical methods. High reliance on ancillary investigations. Very poor attention is given to concept of informed consent. Patients' right to confidentiality is often violated despite clear SLNC guidelines. Severe communication gaps. Extremely poor clinical records. Date, time, identity of patients very often ignored. Any questions? Thank you.